Madas, Regional Quality Head for Eastern and Central Region of Apollo Hospitals Group. Welcome all the audiences, those who are connected on Zoom and YouTube for today's webinar. Apollo Hospitals is conducting the 10 days long pre-conference webinars from 1st of Feb to 10th of Feb. We have a power-packed workshop in New Delhi on 11th Feb, followed by the main conference on 13th and 14th Feb at Taj Palace, New Delhi. Few hygiene factors before we start to our participants. Kindly keep on mute and no videos, please. The question and answer session will be at the end. There are no certificates for the webinar that will be issued, and register separately for the future webinars using the same link. The webinar is streaming live on YouTube, so do spread a word to your team members and other colleagues to learn from the experts. Quality is not an act, it's an habit. When healthcare systems focus on quality improvement, they can create significant change within a medical institution, achieving everything from financial savings to, most important, saving patients' lives. The importance of quality in healthcare sector has been recognized, but it has been accelerated over the last few decades. Earlier, it is difficult to measure the quality of service, but nowadays, the quality of service is evaluated according with 5 fundamental factors, namely reliability, tangibles, responsiveness, assurance, and empathy, and measured by observing its structure, its processes, and the outcomes. So, are these tools really essential for quality improvement? Do we really need to know them? Do they really make a difference? We know about this from our speaker of the day, Dr. Geeta Fulari. Dr. Geeta Fulari is presently working as Deputy General Manager at Shankara Eye Foundation, India, handling quality assurance across 12 hospitals in India. She is also a governing body member of CAHO, representing the quality professionals team. She is a result-oriented professional with master's degree in hospital administration and in ISQA, with more than 10 years of experience in healthcare quality, patient safety, and achieving NABH accreditations and ISO certifications. She has been the faculty for various programs on healthcare quality. She is a certified awards examiner by IMC Ramakrishna Bajaj National Quality Awards and has been actively involved in assessing award applications across industry under IMC Ramakrishna Bajaj National Quality Awards. She has been participating as a jury for evaluating various competitions on a national level. She has also been recognized with Eye Health Hero 2020 award by International Agency for Prevention of Blindness. Over to you, Dr. Geeta.
Thank you, Ms. Suma, for that introduction. And I'll share my screen now. Yeah. So a very good afternoon, one and all. I'm very glad to be a part of this pre-conference webinar. Thank you, Rekha ma'am and Team Apollo for having me. So in the next 15 to 20 minutes, I'll take you through some of the concepts related to quality tools and techniques, and we will see how essential they are for quality improvement. So before we dig deep into is it important or not, we'll first have to understand what exactly quality is. So we have to understand what quality means for the different stakeholders associated in a hospital. Now, as a study that we did in our hospital in Shankara, we went ahead and we asked a couple of questions to different stakeholders as to what quality means to them. We asked our doctors, we asked our nurses, the staff, and other stakeholders. Now, the doctors said that quality for them means no complications, no surgical site infections, less readmissions, low mortality, and so on. Our patients said that quality for them is less waiting time, early discharge, no repeated visits to hospitals, no resurgeries, and so on. So then we were reminded of this story of the 6 blind men when they were asked to touch an elephant and tell that what did they feel they touched. Some of them said that it's a tree trunk, some said it's a fan, it's a wall, it's a rope, and so on. They all perceived it differently. Similarly, in hospitals also, every stakeholder, they perceive quality differently. So if we really want to improve our quality, we'll have to understand what quality means to them and then bring in the processes to improve the overall quality. Now we'll have to understand some primary questions. the first question when we talk about quality is, why don't people do what they think it works? So if we know how care should be delivered, why isn't it being done that way, and how can we make it better? So we know that time taken for admission, it has to be less, but still some of the places we see that it is still an issue. We know that we need to have optimum inventory. We know that effective utilization of manpower is very, very critical. So why does it still take so long for simple advances, never mind more complex interventions, to make it into routine practice? These are some of the primary questions that we need to understand and act upon. Now, everyone must know a couple of important things. So the first one is how to improve quality. Now, when we say quality, there are different definitions of quality. The basic one being healthcare quality, it refers to the degree to which healthcare services meet the needs and expectations of patients and aligns with the established standards of care. So we should know what the benchmarks in quality are, what is the best in class that is available. We should know how quickly the business performs, the speed at which it performs. Now here, speed is the differentiating factor. We should know how to grow business. Business is a growing business. It's all about increasing the revenue. We should know how to make change happen. So when we are talking about change happening, we should know that there are certain protocols that need to keep on changing and evolving. There should be some new processes that we are trying to bring in. So definitely there is going to be change that will keep on happening in our processes. The Institute of Medicine, it did some research, and they used a certain qualitative data and quantitative data, and they have put forth this framework of certain aims for the hospitals. So whenever we are doing any improvement in terms of quality, we should understand that all our services, it will be aligned with these 6 aims that the IOM has put forward. So the care has to be safe, it has to be timely, effective, patient-centered, it should be efficient enough, and it should be equitable. Now let us consider these scenarios. Suppose if you have bought an iPhone for your spouse or for any of your family member, few days later you find an issue in the audio. Will you buy an iPhone again? So it may not be iPhone, it may be any other phone of any other brand. So after you have bought, you find that there is an issue in the audio. Will you again consider buying it? You can type your answers in the chat box, yes or no, whatever. It can be yes or no. So you have bought a phone and then later on you find that there's an issue in the audio output. Will you again consider buying it? So it can be either yes or no. Can I request all the participants to please put in your answers? So some may say yes, some may say no. Okay, so these are the answers. Now let us consider one more scenario. Suppose if you have been on the way to office and now you have entered in a hotel to have breakfast. You have ordered some food. First item, it has come in 10 minutes. The second item, it took almost 30 minutes. Will you order the third item again, though you're interested in eating the third item? Will you order the third item again, yes or no? Please give your response in the chat box. You can say yes or no. Yes, I want everyone to give you answers, please. So will you consider again buying or ordering another item? Yes, so a couple of you are saying yes, a couple of you are saying no. Let us consider one more scenario. Patient's waiting time. Okay, so this is the data that we have on the screen is the minutes to undergo the laboratory test. Now on the left hand side of the column, the first column that we see is the baseline data. So this is the waiting time for a couple of patients where the mean that we found out is 15.8 minutes. Now the managers have bring in some processes and then they are trying to improve it so that there will be less waiting time. So after the measurement, after the improvement protocols have been put in, later on, we are again seeing what the waiting time is. Now, the second column is the waiting time that has been seen after the implementations have been done. And the mean that we see here is 11.2. So initially the mean was 15.8 and post implementation, now it is 11.2. So do you all think the process has improved? Yes or no? You all can again give your answers, please. Do you think the process has improved? Yes, no? Please type your answers in the chat box. Give it a thought and then type your answers in the chat box. Okay, a couple of y'all are saying no, a couple of y'all are saying yes. Can you just type in the chat box if y'all are saying no? Why do you think it has not improved? Yes, exactly. So the mean that we are seeing, definitely it has improved. But then when we try to look at the standard deviation, we will go a little ahead and then we have used some tools and now we are seeing the standard deviation. So the standard deviation, initially it was 7, but now when we see the standard deviation has come to 9. So here there is a lot of variation. So generally what happens is, in most of the organizations, even in the healthcare, we will just rely a lot upon the mean data that is available. We will not go ahead and see what is the variation. So the average based thinking is what most of them they use. So the understanding is importantly based on the average based thinking. So when we look at the mean and then when we do the calculations, when we see the average performance, it has actually improved by 29%. So we look at this and then the average based thinking is that yes, it has improved. So then we start to celebrate. But then who actually realizes it? It is the customer or the patients. The patients, they are feeling the variance and they get irritated because of the variation that is there in the process. So there's too much of variance and there is less equity. So this is what happens in most of the industries. The thinking is usually typically based on averages. So all of y'all who said that the process has improved, so this is the answer. So whenever there is a variation, increase in variation, the customer really gets irritated. So this we saw even in the previous 2 examples also. So there was a variance in the audio output of the phone that we had ordered. There was a variance in the time that was taken for the food to get delivered. So whenever there is a variance, the customer becomes a little irritated and is not really sure whether to go ahead with the service or not. So this way, there are a lot of healthcare challenges that today we need to address. There is a rising cost of healthcare. There are deaths due to medical errors, and there may be even the medical complications that occur because of some wrong dosage or any medication errors. There may be aging population that we need to address. There's shortage of doctors and nurses. Shortage of nurses, I'm sure most of you all will likely can see in most of the hospitals. There's complicated processes and systems that we need to simplify. There's high percentage of caregiver time that is spent doing paperwork. Patient satisfaction is something that we need to address. We need to bring in patient delight. Employee satisfaction is again something that we need to think about. So these are all the various healthcare challenges and we need to act right now to address it. So how do we address it? Our customers can only feel the variation. They cannot feel the mean. Reducing process variation is very important. Challenges are there in patient admissions, discharge time, testing, diagnosis, etc. All of them exist. Reduction in process is extremely important. Now we know that all of these challenges are there. So how do we really address it? Is it only that some discussions in the boardrooms that we do or in the departments that we do and some brainstorming that we do and then we can come up with the solutions? Not really. It is not always possible. So measuring quality is also very important. And how do we do that? With the help of quality tools. So just like a mechanic uses a couple of tools to do his job, a doctor may use stethoscope, torch, thermometer, and so on to examine the patients. An accountant may use spreadsheets, some Excel sheets, and so on to do their job. So as healthcare managers and quality professionals, what do we have as tools? Do we really have some tools that we can use? The answer is definitely yes. So today there are a lot of tools that are available and all of these are proven tools. If we make use of them, our life will be much easier. So what is the importance of using these quality tools? How does it really help us? So at various stages, if we use it at the right time, it will help us to collect data. It will help us to analyze the data, identify the wastes and eliminate it. It will help us to understand the process, identify the root causes, identify the solutions through data stratification. It will help us to measure the results and control the improved state. So these are all the different various uses that we will realize if we start using the quality tools. Now, Mr. Koro Ishikawa, who is one of the pioneers in quality, he has rightly said that as much as 95% of all the quality-related problems can be solved with the 7 fundamental quality tools. And trust me, when you're beginning with any QIP, any quality improvement project, if you make use of these tools that are available, then it will like more than 50% of the job will be done very, very easy. So what are these tools that we are talking? So there's flowchart that we have. So flowchart, it will help us to understand the process better. Whenever there is a new joinee in the hospital or you are coming up with a new process, just create a simple flowchart and then display it in the department. So staff, they can see it and they can understand what the process is and it will be much easy for them to follow it. And there will be high compliance. That's how it helps. We have cause and effect diagram. I'm sure most of you all might have used it. It will help us to identify the various causes that are contributing to a problem. We have control charts. So control charts, they'll help us to monitor the process over a period of time. It will help us to understand whether a process is really in the control limits or not. We have checklist or the check sheets. It will help us to collect the data at a particular place. We have histograms. So histograms are also very, very efficient tools. When we have a huge amount of data that we want to present quickly and easily, we can use it. So histogram, it uses a large amount of data, but we have to understand that the data has to be continuous and it has to be, in numbers. It has to be a quantitative data. Only then we can use it. Then we have the Pareto chart. Pareto chart also, most of you all might have heard. It helps us to prioritize those causes which are causing the maximum problems. So it is based on the 80:20 rule. You address the 20% of the reasons, you will be able to solve 80% of the problems. Then we have the scatter plot. So scatter plot, what does it do? It helps us to establish the relationship between the cause and effect. For example, if you want to really identify that whether the time spent by the doctor is causing an impact on the patient satisfaction or not, scatter plot we can use. Or when you're done with a fishbone diagram, and if you want to understand whether a particular cause is really having an effect on the problem or not, we can use a scatter plot. So these are some of the advanced tools that you can see. We also have the arrow diagram, which helps us to organize the ideas into categories. We have the matrix diagram, which helps us to visualize the complex relationships. We have the affinity diagram, which helps to unify a large amount of data by finding the relationship between them. We have the tree diagram, which helps to break down large information into simpler categories. We have the house of quality or the quality function deployment. It helps to define the relationship between the customer desires and the product or the company's capabilities. This is again a very, very wonderful tool. You all must use it at least once. We have been actually doing a project at Shankara, and we have found this tool to be really useful. It helps us to match the voice of customers and then align it with the company's capabilities. So very, very good tool. Taguchi method, it helps to optimize the design parameters and helps to minimize the variation. We also have the FME, failure mode and effect analysis. Again, I'm sure most of the NABH hospitals, they definitely do have it. It helps us to identify what are the failure modes, what is the effect, how to analyze it, how to come up with the mitigation measures, and who would be responsible within the whatever timelines. So all of that data will be available in the FME. So very, very beautiful tools that we can use. Now, plan, do, check, and act. So this is very critical for the continuous quality improvement. So PDCA cycle that we call it is also called as the Deming's cycle. So whenever we want to do any quality improvement project or we want to sort out any problem in the hospital, we can use this particular PDCA tool. Now, if you're wondering what tool we have to use when, then this is when we can use what you can see on the screen. So in the plan phase, we can use the flow charts, cause and effect, Pareto charts, check sheets, histogram, control charts, and so on. In the do phase, we can use check sheets. In the check phase, we can use check sheet, Pareto charts, histograms, scatter diagrams, control charts. In the act phase, we can use the flow chart, scatter diagram, and so on. Now, it's not a hard and fast rule that these tools have to be used in these particular phases. Depends on what is the issue that we are trying to address or what the condition is. Accordingly, we can use the tools. So this way, there are a lot of tools that are available when we want to go ahead with continuous improvement in our hospitals. So there are different tools like this 5i, there is 5s that's available, value stream mapping, mind mapping, and so on. From the basic tools that are available, we can go ahead using the advanced tools. So there's also Six Sigma that is available now. Six Sigma is a combination of the different tools that we can use to solve the issues. So Six Sigma, any company which has achieved the Six Sigma, what does it tell us? So it tells that this company is on the highest level of quality. So it's not very easy to achieve the Six Sigma level on a company level or on an organization level. Organizations have to work really hard to achieve Six Sigma. It can be some of the processes which they can achieve Six Sigma. But again, it's a wonderful tool that we can use in most of the hospitals. So can anybody tell me which Indian company has got Six Sigma at a company level? Anyone in the audience? If you can just type in the chat box. Tata, okay. Any other company that you all think? Toyota, okay. Which is the Indian company? Let's talk about Indian company. Yes. So not Motorola and not Tata's. So it's the Dabbawala. I think Mr. Sudeep has put the right answer. So only the Dabbawalas is the company in India that has achieved a Six Sigma on a company level. So there are a lot of other companies who have achieved the Six Sigma, but only for a certain process, not on an organization level. So we can also make use of a lot of these tools and go ahead with the quality improvement. So are quality tools really useful? Let us address this basic question. So what do you think? Definitely yes. So 100% quality tools, they definitely help us to go ahead with the quality improvement. So how do they really help us? They'll help us to identify and solve the problems. They'll help us to improve the efficiency and effectiveness of the process, reduce the defects and the waste, and enhance customer satisfaction. It will help us to achieve and sustain continuous improvements in quality, and also it will help to improve the overall organizational performance. But the most important thing is to understand which tool has to be used when. So there's absolutely no excuse for learning. If you all are still thinking that I do not know what these tools are and when to use it, that cannot be an excuse for learning. You can just approach someone who knows about these tools and how to use it, or you can just simply Google it. You'll get a lot of information. There's also ChatGPT today that is available. It's a beautiful AI tool. You have any questions, you just put it there and then it'll answer you on a click. So yeah, when I was preparing this presentation, I did make use of the ChatGPT. So I thought I'll just take a screenshot and put it over here. So there are lots of beautiful tools that are available that we can use. There are a lot of webinars on YouTube that you all can refer. CAHO has got training programs. CAHO is the consortium of accredited healthcare organizations. So a lot of training programs are available. You can go on the CAHO website. There's a dedicated training program that is available for the tools and techniques, the basic tools and techniques. QCI, the Quality Council of India, also has a program on the implementation of the tools. And you don't have to use any simple, complicated softwares to learn these tools. You can use your simple Excel, and data is what is most important. You get the right data and then you use the right tool. And with the help of an Excel sheet, you will be able to, create all of these tools. But the most important thing that we need to remember is to involve the stakeholders. So only when you involve the stakeholders, you get the information from them, you involve them in the process, only then the implementation becomes easy. We'll be able to understand the problem much better. Again, using the right data is very, very useful. Using the right tool is again very, very critical. We cannot use a spanner in case of a screwdriver. So similarly, we cannot use a histogram in case of a Pareto chart or any other chart. So using the right tool at the right place at the right time is extremely important. And then once we are done with all the analysis and we have come up with the various solution structure, it's important that we implement these solutions. And after we have implemented, should not forget it, but then a regular review again is very, very critical. A regular follow-up is very important so that we can go back and see whether all the analysis, the data, the tools that we have used have been really at the right place and whether they are serving the purpose or not. So measurement is measurement is the foundation of a building improvement. Using the right data and the right tools are extremely important and they're very critical in quality improvement. And to end with, I would just like to leave you all with this thought. So today there's a lot of responsibility on the managers and the quality professionals. So we need to, really bring in that confidence amongst all of our staff that quality tools are really helpful. So we should just practice before we preach. So using the right tools and the right data is very, very critical. And we have to, convince all the staff that this is the fundamental approach in improving quality. And these are some of the references. Thank you. Ms. Suma?
Yeah, thank you so much, Dr. Geeta. I think it was a wonderful and interesting session with the examples and the various quotations which you have given. And most importantly, the take-home messages could be: quality tools provide a systematic approach to identify and solve the problems, improves the efficiency and effectiveness of the processes, reduce defects and waste, enhance the customer satisfaction. Implementing these tools can help the organizations to achieve and succeed in their various goals and ensure continuous quality improvement is there. With the use of various advanced tools and continuous quality improvement techniques that you have elaborated, I'm sure our participants are going to be very, very, enriched with this. And the best part, what from your presentation I liked, and I think I'm sure our audiences also will grab, is the R's, the right R's, the right data, the right tool at the right place, the right time, definitely gives the right solution. And I think that's the reason all of us are here. Thank you so much once again, Dr. Geeta, for that informative session. And reiterating what Mr. Kairo Ishikawa has told, that as much as 95% of all our quality related problems can be solved with the 7 fundamental quality tools. No excuse for learning. And at the end, with measurement is the foundation for building improvement. Thank you so much. It is believed that the quality control tools were introduced by Koro Ishikawa in post-war Japan, inspired by the 7 famous weapons of Benki. Benki was a Japanese warrior monk who armed himself with 7 weapons and was on a personal quest to take 1,000 swords from the samurai warriors who he believed were arrogant and unworthy. So the 7 basic tools of quality control are similarly the most crucial tools for quality management. These 7 tools are very easy to understand and apply in our day-to-day lives for quality improvement. Without much ado, let's learn it from our next speaker, Dr. Dr. Sunil Mundrekar. Dr. Mundrekar has done his MBBS, DCH, DNB Pediatrics from MAN NIMHANS. He's also done his MBA in healthcare management. He holds a degree of PGD MLE from the NLS Bangalore. He's also a professor of pediatrics, Kasturba Medical College and Hospitals. He was also associated with QMR ISO 9001 and 14001 and Accreditation Committee of Kasturba Hospital. Presently advisor there. Lead SSR for ISO 9001 and 14000, Principal SSR and National Level SSR's trainer for NABH. Also SSR for NABH Emerald, NABH Entry Level, NABH SHCO and ACHS 1, that is Australian Accreditation Standards. Not only this, he has many publications and presentations in journals and conferences, both in quality and pediatrics to his credit. Over to you, Dr. Sunil.
Thank you, ma'am. And I hope I'm audible as well as visible.
Yes,
My
sir.
voice
You're
is
audible
clear?
and visible. Yes, sir.
My voice is clear, right?
Absolutely, yes.
Okay. Now, it's very, very challenging to talk on quality after Madam Dr. Geeta Fulari's deliberations. Thank you for that introduction. And I bring greetings from Manipal. I'm working right now in Manipal, the birthplace of the Manipal institutions. If it cannot be measured, it cannot be monitored. And if it cannot be monitored, it cannot be managed. That's what Peter Drucker said. So this is applicable to all facets of management, including quality management. So if you want to manage quality in the hospital, you need to monitor it. And if you want to monitor it, you have to measure it. Quality and measurement, is that possible? Most of the administrators talk to the quality executives like that. Can quality be measured? The answer is actually yes. It has to be measured. And if, as a quality executive, you have not measured it at the end of 2 years or 3 years in your organization, instead of becoming a quality executive and a very strong person, you will become a biomedical waste. So, as already told, Ishikawa, a Japanese professor of engineering, originally developed the 7 quality tools in the 1950s to help workers of various technical backgrounds implement effective quality control measures. And these are still considered the gold standards, and we still use in quality. When I asked my executive to collect data on doctors' consultation timings, this was the data given to me. I could not interpret anything. And it's the same thing when you also collect the data and you don't know what to do with the quality, what to do with this data. And later, the person gave me a very, very beautiful diagram showing the patient waiting time in minutes. Look at the way it has been predicted, it has been depicted, and that is the advantage of the measuring quality and improving on it. The importance of using tools is for delivering effective presentation. Simple visual way of viewing the data. You saw how a table or column is converted into a very beautiful graph. Useful advice to teams trying to establish facts about what's happening, displays large amount of data at a time in 1 slide or 2 slides, and presents data accurately so that you can make valid decisions at the administrative level. So those are the important advantages of having tools rather than just making it cosmetically beautiful. These are the 7 basics of basic quality tools. As madam has already told, there are some advanced tools and there are some other tools also. So I'll be concentrating on these 7 basic quality tools: the histogram, Pareto charts, cause and effect diagrams, scatter diagrams, control charts, flow charts, and checksums. I'm sure that all of you are aware of these the basic statistical tools, that's the mean, median, and mode, most commonly used, and the standard deviations. I will not go into the depth of it. Those who are not aware of it, please kindly make a note of it, because a lot of things will be discussed on these statistical tools. So first, let's move one by one. The histogram. It is for illustrating the frequency and the extent of 2 variables. So you need to have 2 variables here. Histogram is a chart with the columns which represents the distribution by mean. And if the distribution is normal, then you get a classical, the bell-shaped curve. If the graph is in the bell-shaped curve, if the distribution is normal, but if it is not normal distribution, it may take different shapes based on the condition of the distribution. Histogram is used to measure one variable against another. So you need to have 2 variables and data should be numerical. The basic essential point for you is the data should be numerical. When is it used? It is to communicate the distribution of data quickly and easily to others, and it helps in decision making, graphically summarizes the large data and compares performance to expectations or specifications. Look at this data. This data was collected for the reasons for dissatisfaction at the OPD level. So around 400 feedbacks have been collected, and these are the common reasons or negative feedbacks given by the number of patients. Now, what to do with this data? How to analyze this data? So this was converted into a histogram, and now you can easily see the 3 most common causes of dissatisfaction. So that is the strength of the histogram. You can easily easily make out that insufficient doctors, insufficient counter staff, and registration time is too long, where the 3 causes for dissatisfaction, and then you can immediately take action into that. Next comes the Pareto charts or Pareto principle. Pareto charts are used to identify and prioritize problems to be solved. Now you have to identify the cause. Now you have to act on Pareto charts. Vilfredo Pareto in 1800, Italian economist, noted 80% of wealth was held by 20% of the population. This was his thought, which Juran applied this Pareto principle, stating that 80% of the variation is in processes by 20% of the variables. 80% of the problems are due to 20% of the 80% of the problems can be solved by 20% of the causes. Vital few as opposed to trivial many areas we discuss. It is also called 80-20 rule, but need not be always 80-20. It can be 75-20, 70-30, or even 65-35. The concept is to prioritize and address the issue. Let's go back to the same data before that. Looking at the data on the frequency of problems or causes, you can, when there are too many problems or causes and you want to focus on the significant ones, when you want to analyze broad causes by looking at their specific components and to effectively communicate to others about the problem or data, we use Pareto principle. And when you want to quickly solve the challenges and issues, Pareto principles are used, because if you solve these 20% of the causes, 80% of the problems will be solved. Let's go back to these feedbacks, and that's what we saw. Now you arrange them in a descending fashion. For 111 feedbacks were on registration time too long, 100 insufficient doctors, 93 insufficient. So you have assembled them or reassembled them in a descending order. Now, after assembling them in a reascending order, then look at the cumulative, calculate the percentage. So 111 out of 400 comes around 28%, 100 out of 400 comes to 25%. So you calculate the percentage, and next step is to calculate the cumulative frequency. That means to say, if you see registration time too long, it was contributing to 28%. In addition, insufficient doctors contributed to 25%, so it becomes 53% added together. Insufficient counter staff added 23%, so 76%. Now you see cumulative frequency, 76% of the problems are because of the three causes. That means if you solve these 3 challenges, you will solve 76% of the problems. So 76% negative feedbacks can be prevented. That is what's called Pareto principle. You can again redo it in the histogram and see that 76% of the problems are because of these 3 challenges. So this is become 76 and 24 here. So you can have 70-30 or 65-35. The cause and effect diagram or fishbone is another very important tool, and that is a very important tool when you have multiple root causes for challenges. It's a schematic way of relating the causes of variation in the process, a drawing to organize the contribution causes to a problem in order to prioritize, select, and improve the source of the problem on the right side and the possible causes on the left side of the fishbone. The causes are broadly classified into 5 M's and 5 E's. I'm sure most of you will know. These are to be used when identifying possible causes for a problem and when there are multiple causes and multiple process owners involved. Identifies areas for collecting the data and good process knowledge from multiple stakeholders useful for teams focusing on discussion and organizing large amounts of information coming from a brainstorming session, and especially when a team's thinking tends to fall apart and concentration is lacking. This is the common fishbone skeleton. When there is an effect, when there is a defect, you think of what are the policy decisions that need to be changed, what are the people or man, material, procedures, methods, or machine that needs to be changed to get this effect. Or if you want to say defect, or how many of them contributed to this effect. For example, this time, if you take registration time too long, staff can cut the queue registration at any time. So you identify the causes and then solve. For example, insufficient clarity in work, multiple sessions in a session time. You find out the reasons and write down the form of fishbone. What are the reasons related to methodologies? What are the reasons related to machines? What are the reasons related to people? And what are the reasons related to environment and controls? And write down, because it will be easy for you to do the corrective action, preventive actions, because those related to the people can be managed by HR, those related to machine can be managed by operation team, those related to methodology can be related by quality, both which are related to environment can be handled by engineers. And similarly, it is easy to identify the process owner to rectify and correct the solutions. So similarly, once you correct this, again, you can go back to your fishbone, and try to rectify each and every problem related to that and how you can control these processes and how you could achieve the how you could achieve the reduced waiting time. So that is a very important tool and very often used. The third one is a scatter plot. Scatter diagram shows correlation between two variables. So when there are two variables, and when you don't know whether they are related to it or not, then you can use scatter plots. If correlated, it does not mean a direct cause and effect. If one variable can be predicted based on the value of the other, then it is correlated. It may not be in confusion. It may be in confusion. For example, this is a positive correlation and this is a negative correlation, and these are not correlated. So you plot these findings in the X and Y chart and see how the relation is. I'll explain this with an example. Trying to determine if the two variables are related or not to identify potential root cause of the problem. After brainstorming session and identifying causes and effects using a fishbone diagram to determine whether a particular cause and effect are related. For example, time spent by doctors and its relation with that patient satisfaction. So you plot the time spent by doctor in one axis and satisfaction score given by that patient in another axis, and see whether they are related or not. The common thinking is if you spend more time with the patient, more satisfied the patient will be. And when you plot the diagram, it's proved. The same data what you collected is plotted, and you see to it that there is a positive correlation. That means if you spend more time with the patient, if you spend more than say 20 to 25 minutes, the satisfaction level may be more. And if you plot further, let's say the patient has spent 30 minutes, 40 minutes, 50 minutes with that, then it may be again maybe a dissatisfaction level or so you may get such relation. Then this scatter plot shows the positive correlation between the time spent by the doctors and the satisfaction score. Next comes the control charts. Its influence of special causes on process out of control situations. Monitor process to show how the process is performing over time. So here you need to have some statistical principles, upper control limit, lower control limits, etc., and that can be calculated from the data. For example, the time between the glucose measurement in hours. You got the data, and now you don't know what to do. And sometimes it will be difficult. So you calculate the mean and the standard deviation. There are statistical tools available. You can use the Excel sheet to calculate the mean and standard deviation and see how often there is a standard beyond the upper limit and lower limit. So you can decide the upper limit of control, that is mean plus 3 standard deviations, and lower limit of control is mean plus minus 3 standard deviations. So anything between 10.54 and 1.14 is okay. Still the process is under control. So you again relook into this, and then you will understand that only in the month of on 9/2/2021 you had things going beyond control. Upper limit of normal going beyond upper limit of normal. So that is the you can find out that why this happened on February 11th, because the corresponding data was above root cause for variance need to be investigated. On this point, what happened? Although there is variation, although there is deviation from the mean in the entire data, you need not bother about these findings, because they are still under control, because they are within the 3 standard deviations. And only one day, there's a 9th February, you had going beyond the 3 standard deviations, and that is where you need to control. That is called control charts. Control charts are made with existing data. Suggestions, if necessary, are implemented based on the chart. Post implementation, the mean and the control limits of the control charts will vary depending on the effectiveness of the implementation, and they are helpful for analyzing the process before and after an improvement, and helps to see how process mean and variability change as a result of the improvement. This is another example of the time taken for admitting the patient in minutes and how it is controlled. For example, in the June, it was taking a longer time. Then we have implemented the process, and then it came down, and now it is very less, and it's the entire process is brought under control. And the deviation, if you see, in the month of July and August, we have come down on the standard deviation. Now it has come down within 1 standard deviation, which it was 3 standard deviations in the first month. So reducing delay, these are some of the examples. Reducing the delay for patient admitted to the emergency department, as I've already discussed this. Next one is the flow chart, process flow chart or flow diagram, a powerful improvement tool to define, describe, and communicate clinical, administrative, and operational procedures. A flow chart represents an algorithm or a process with the help of pictorial syntax. They trace the shape, steps, the object of the process goes through from start to finish. Lab test or clinical visit, specialty test or imaging study. Boxes of pictorial symbols connecting the arrows to represent sequence of activities, and flowcharts help to identify points or bottlenecks where problems might occur. And they develop understanding of how a process is done. This is useful when you are implementing quality, ensuring quality in a single process from beginning to end. Study a process for improvement. Communicate to others how process is done. When better communication needed between people involved with the same process in order to document a process while planning a project. For example, these are some of the symbols used in the flow chart. The one step in the process, direction flow, decision based on a question is this one, delay or wait, link or another. So this is a classical flow chart which we use more often in our day-to-day practice. And if you write down the flow chart and at the same time write down who is the responsible person and then see where actually delay happens, then it is easy for you to understand and solve the problem. For example, the delay in dispatch of reports from the lab, and when we study or time motion studies, delay in discharge of the patient from the ward. These are the things where you can use a process flow and find out the bottlenecks. For example, issue of the blood from the blood bank is not done because the consent is not coming with the patient's request for blood. So rectify the process so that the delay is minimized. A lab report is being delayed because there is no typist to type the lab report. So a Aya or a housekeeping staff was typing the report, and that was the reason for the delay. So you appoint a typist to type the discharge summaries, type the lab reports. The delay in the lab report turnaround time has minimized. So that's how you can use flow diagrams to control the whole process. This is another example of a flow chart. The next one is a check sheet. It's a defect concentration diagram. A check sheet is situated, prepared from the collecting and analyzing data. This is generic tool that can be adapted for a wide variety of purposes and a simple document used to collecting data in real time and at the location where the data is generated. When data can be observed and collected repeatedly by the same person or at the same location, we use these check sheets. When collecting data on the frequency of patients, of events, problems, defects, defect location, defect causes, etc. When collecting data from the production process, we use these check sheets. These are the classical check sheets which we use. One classical example we use is say for adherence to safety precautions by employees working in the radiology department or lab department. So one person checking these data in various days and then find out where is the problem and how many days. For example, in the example given in this, 28 defects were identified on Saturdays. So Saturdays you need to concentrate on, and most of the discharges do happen on Saturdays because Sunday is holiday. And that's why if you see late discharges do occur on Saturdays. However, on Wednesdays, staff are not punctual for duty. There may be some reason why the staff is not coming on Wednesday. The punctuality is lost. So you need to address this on Wednesday and you need to address the late discharge on Saturday. Then the improvement will be easy. So that is the strength of the check sheets. So in nutshell, when to use these charts, histograms categorize large amount of data. When you analyze the large amount of data, say sample size of 2000 to 3000, then you will use histograms. Pareto charts, when you want to prioritize the problems, 20% of the problems, 80% of the problems can be solved by 20%. When you want to quickly solve a challenge or problem, you use Pareto charts. Cause and effect diagrams find possible causes for a problem when there are many causes and you need to fix these various related problems, like sometimes the Swiss cheese problem. So there's a problem with the material, there's a problem with the man, there's a problem with the money, all those things. Then you use the cause and effect diagrams to sort it out. Scattered diagrams, when there are two variables and you don't know whether they are related or not, and see whether their relations can be sorted out. And control charts to check if the process is under control or not, where you see whether it's in between 3 standard deviations and 2 standard deviations, and bring the control from. What is important is decide what factor to measure, determine the method of measurement, identify the appropriate tool before stage number 2 or step number 2, validate the data what you have collected. That is very, very important, because if there is a data bias or a collection bias or selection bias, then the entire data will have no meaning and there will be skewed deviation. So decide what factor to measure and determine the method of measurement. Establish quality assurance procedures in these, checkpoints and bottlenecks to be identified. Create and standardize policies for future quality measurement accordingly. And control the processes. Like say, if we want to put an SOP there, you can put an SOP, you can put a checkpoint, for example, without a consent completely filled up, the patient cannot be wheeled inside the OT, or these kind of studies, and create standardized policies to prevent the deviations and deficiencies that can happen. And revisit quality standards periodically. The one step ahead may not be applicable all the time, so you may have to review periodically to see whether it is applicable or not, or continuously suitable or not. So with that, I conclude the basic qualities, basic tools of quality. I'll be all the more happy to answer all your questions. Madam.
Thank you so much, Dr. Sunil, for taking us through the basic tools of quality control for process improvement with your live examples and very effective illustrations. I must say you have tried to summarize a 3-hour movie into a 10-minute session with the same effectiveness. So thank you so much for that. I'm sure the audience, those who are connected and those who will be listening to it later, will be benefited immensely with this. They must be able to be aware of the various quality tools and how to utilize them, use them in their day-to-day life, when and how to use and make them more effective, and the various other mantras which you have shared. So I'm sure that the team is going to be immensely benefited. Are there any questions? We have a question from one of our colleagues, and she would like to know, sir, this question is to you, that in which cases do you prefer to use a scatter diagram? If you can kindly throw some light on that.
I had already shared when to use scatter diagrams. When you don't know whether there's a causal relationship between the reason and the effect. So when you don't know, then you use scatter diagram and see how whether it's positively correlated, negatively correlated, or not at all related. So when you don't know the relation between the cause and effect, you use the scatter diagram.
I think that aptly answers the question. There is another question in the chat box for you. I think Dr. Bharat wants to ask this. Even Dr. Geeta can take up this. Do you think, or we use the box plots to compare between various department performances? Do you suggest that, Dr. Geeta?
See, box plot, it can be used. So basically, when will you use a box plot? When you want to display the number summary of a set of data. So that is when basically a box plot is used. So you can use it. There's nothing that stops you from doing so. So you can just you can get the baseline data. You do a box plot analysis, and then yes, for both the departments, you can compare and see to conclude, to analyze and then to conclude. So you can try.
I think the more we try, the more we get a hold of this. That is what Dr. Geeta wants to tell all of us. Another question to you, Dr. Sunil. There are if there are 7 data points, either above or below the mean, but still within the basic control limits, what do you suggest? What kind of tool should we use in that case?
Yeah, when it is within the range, when it is under control, you need not worry about it. Or if you want to have a strict control where the deviation is not acceptable, you can minimize the deviation by reducing it to 2 standard deviations or 1 standard deviation, and then try to control exactly what level of control you need. That is more important. So if you want it, if it is within 3 standard deviations, if it is okay with you, then you can stop at that point. But if you want to have much more stringent control, then you have to reduce the standard deviations into 2 and 1 and see whether there is a deviation that's happening. That's a better way to control them.
Yes, absolutely.
That's
absolutely. If I can just add to it, so
please.
Yeah. So see, now the control chart, when we will use when we want to identify whether a process is really in a state of control or not. So the basic thing, when we want to come up with the upper control limit and the lower control limit, we will use the formula. So 3 into like whatever. So we'll use the formula. And in case if over a period of time we see that yes, it is in a period of control, then we can again do some benchmarking. You can benchmark it with the external organizations, or internally you can benchmark, and then we can modify the UCL and the LCL. Again, going a step further in the third scenario, if you think that your process is now much in control, you can still modify the upper control limit and the lower control limit to again narrow the control limits. So step by step, you can modify your upper control limit and your lower control. There's no strict or hard and fast rule that you have to stick to only one UCL and LCL. Yeah,
the thing is, to what extent you want to control your process, that should be very clear. Absolutely. If 3 standard deviations are acceptable, then we stop at that point and we will not have such a narrow control.
Absolutely.
I think that really answers the question, and it is our own quality benchmark which we want to fix for our institution or our department. I think that defines the thing. There is one more question, I think open to both of you, whoever wants to attempt to this. To identify medication error and the causes, which tool do you think is most effective? I think a problem which all of us come across on a day-to-day life.
Yeah, the Ishikawa charts and even Pareto diagrams can be used. It depends on how are your root causes. So Ishikawa charts will help you whether it is a error related to documentation, whether it's because of prescription, whether it's a transcription, whether it's administration or dispensing or monitoring. So you can accordingly identify the process owner and identify and minimize it. We by using a Ishikawa chart, you will know exactly which are the causes, which are the most common causes for your medication errors. You can use 2 tools together. For example, if you say that the problems are because of the prescriptions and administrations, then you need to concentrate on nurses and the doctors to make it more clear and legible, so that 80% of your problems can be solved by addressing these two professionals, so that your 80% of the medication errors can be minimized. So you can use two principles actually there to address your medication errors. Madam, you want to add anything?
No, sir, I totally agree with what you have suggested. And in addition to that, I think we can also use a simple check sheet. So if we want to identify what type of medication error is happening in a particular department, just prepare a simple check sheet to the staff and you give it to them, because check sheets are very, very easy that the staff can understand what they have to use. So just jot down what all you think medication errors, the possibilities there in that department, guide the staff how they have to use it, and whenever they find that there is any medication error, they can just give a tick mark against it. So over a period of time, say in a week or a fortnight or a month, you can then compile all the data to conclude on what have been the major medication errors. So this is in addition to what sir said.
Thank you so much. I think indeed those were the to-the-point answers, and I'm sure everybody is going to get benefited. So once again, I would like to express my generous thanks to our esteemed speakers for taking out time from their busy schedule for this session and making it so easy to understand and so implementable. That is the main thing. Thank you once again to both of you. And thank you, lovely audience, for joining in and learning what we can and learning how we can make a difference with the tools which are there with us. Is just that we have to make an effort. And as said, it is performance ready if you can play 7 times without error. So go for it and try all the tools, 7 tools and beyond it, so that you can actually make a difference and improve the quality assurance of your department, of your organization. We have few more webinars to go in this entire series of pre-conference webinars. Tomorrow's session is extremely crucial on supply chain management. We have eminent speakers who are going to explain all about what you need to know in the supply chain practices in healthcare scenario. So don't forget to register yourself on the same link and join the session. Last but not the least, if you have not registered for our upcoming conference, 9th International Patient Safety Conference at the Taj Palace, New Delhi, which is going to be held on 13th and 14th of February. You still have a few seats left. Please go for it. Do it right now and book your seats for a value-added experience altogether. So once again, thank you so much for giving your precious time and making a difference. Thank you once again and have a very good day.
Thank you, ma'am.
Thank you.
Thank you.